Let's elaborate on isolation before we demonstrate it. First, it is important to understand that there are an infinite number of circumstances, and it is impossible to provide one set of explicit instructions that will work for every patient. Moreover, there are a huge range of possibilities that can all give the same result. Our high-level goal is obtaining good, consistent, reproducible regions of interest. Isolation and rotation are only steps towards that goal. A little more or less soft tissue will probably not affect the results. Holes that are not in the ROIs are inconsequential. Don't obsess over soft tissue and bone holes, but don't ignore them either. Trim and fill with discretion. Let's experiment with our example now. On this example, we can see significant soft tissue on the femur that needs reduction. The question is, how much? Let's determine this by experimentation. First, let's look at the ROIs from an unadjusted image. Note the rough contour of the femur being caused by the residual soft tissue. Note the total BMD value is 0.891. Let's trim once and look at the results on the ROI window. This trim resulted in smoothing of the femoral contour, a change in the BMD value to 0.920, and a slight degradation of the rotation. Let's trim several more times and see what happens. Trim 2 removes more soft tissue, improves the rotation, and gives us a measurement of 0.893. Trim 3 removes more soft tissue, degrades the rotation, and gives us a measurement of 0.919. Trim 4 removes almost all the soft tissue, gives us a good rotation, and a measurement of 0.890. It also introduces a hole in the femoral head. We can conclude from this experiment that 2 trims were the ideal for this patient. More trims were unnecessary, even though some soft tissue was still visible on the femur. A small amount of residual soft tissue is not a cause for concern because the density of soft tissue is low compared with bone and contributes very little to the areal density measurement. Holes such as the one which appeared after the 4th trim and which are not in the ROIs are inconsequential. However, soft tissue removal to a point where bone is eroded and the contour of the femur is altered, or holes are introduced in the ROIs, can have detrimental effects on the ROIs. Let's reset, trim twice for our ideal isolation, and move now to rotation. Let's reiterate our goal for rotation: to make the femoral neck as parallel as possible to the projection plane. Let's use a shadow analogy to create a picture in your mind of what we want to accomplish. Imagine a shadow is cast by the femur. If you rotate the femur, the shadow changes accordingly, as seen in this example. Our goal is to rotate the femur until the neck casts the perfect shadow for a particular patient. So what is and how do we achieve a perfect shadow? A perfect shadow is cast when the hip is as parallel as possible to the projection plane and thus casts the largest shadow. Here's how you do it. Begin by scrolling the coronal image to find the lowest point between the neck and greater trochanter. Then set the crosshairs in the bottom of this valley. A view through the neck is now displayed on the axial image. Let's scroll up and down to get a sense of the ideal level to assess rotation. This is a little too low. This is a little too high. This is just right. We have the maximum view of the femoral neck. If the two lines of anterior and posterior cortical bone in the neck are straight and parallel, rotate the neck until these lines are parallel to the horizontal reference line. If the two lines of cortical bone are not parallel, drag the reference line to the middle of the trochanters, split the difference between the anterior and posterior neck, and rotate the neck until it is as horizontal as possible. You can expect to see wide variations in femoral neck size and shape. Correct orientation of the neck should be your main focus, but it is also desirable that the femur be oriented like a vertical tube. Additional rotations of the sagittal and coronal images can be attempted to achieve this. Looking at the sagittal image, the femoral shaft should be vertical. The coronal image should look similar to an AP hip X-ray or DXA image. The vertical reference line should pass through the neck trochanter junction and be in the center of the distal shaft. Adjustments to the sagittal and/or coronal images may degrade the axial rotation, necessitating its readjustment. Like isolation, rotate with discretion. You can rarely improve upon the automatic rotation if the scans are good to begin with, and unnecessary rotations may degrade the ROIs. With our example, no adjustments were actually necessary. Note that rotation begins on the CT table. The more successful you are rotating the patient's femurs outward by rotating the feet inward, the greater the odds will be of a good and successful automatic rotation by QCT Pro. The best way to develop a good understanding of isolation and rotation is, in a word, experiment. Try experimenting with various combinations of trimming, filling, and rotation, and comparing the results of the ROIs. You can always return to the rotation window and click Reset to revert to the unadjusted state. If the ROIs are inadequate, experiment with adjustments systematically to find out what is critical to getting proper ROI placement for that particular case. Recognition of what is critical to getting proper ROIs is ultimately the skill you need to develop in order to do good hip analyses. Isolation and rotation are subjective processes. Use discretion and strive to produce good scans which will improve the odds of a successful automatic isolation rotation and lessen the necessity of your intervention. Click the ROIs tab to go to the next step. The ROIs reflect the quality of the scan, isolation, and rotation. If everything is right, the chances are good you will not need to make any adjustments. If the ROIs are flawed, you can make adjustments, but you should also attempt to understand the cause to facilitate learning CTXA. We will now describe proper ROIs and demonstrate how to make adjustments. The femoral neck ROI should be centered in the neck and rest on top of the greater trochanter. The location of the neck ROI is adjusted by dragging it along the neck axis line. A small amount of greater trochanter in the neck ROI is acceptable. The ROI should be perpendicular to the neck axis and should not include any femoral head. The angle of the ROI can be adjusted by dragging the red axis line along an arc. The ROI height can be adjusted by selecting either 10 or 15 millimeters from the ROI height size box. A shorter ROI can be used to exclude femoral head or compensate for a small neck. The distal extent line should be at the base of the lesser trochanter. Its location is adjusted by dragging it. The automatic ROIs were initially correct, so no actual adjustments were necessary on this example. Click the Results tab to go to the Results window. The Results window is a view-only window showing the outcome of your analysis. For example, the patient is compared to norms for the total hip and femoral neck. T-scores are calculated. Click the Report tab to go to the last step. This is the last step of the analysis. The analysis results are saved and reports may be printed. The results must be saved before reports can be printed. Information such as a doctor's name and an interpretation can be added to the report. In this example, we will add a doctor's name and interpretation using choices previously defined with the list editor. After any edits are complete, click on Save Exam Record. A confirmation message, Exam Report Saved, will appear below the Save button, and the Print Report button will activate. Reports may now be printed. This concludes the analysis of this examination and this tutorial.